Hi everyone, I'm Dr. Jing Liu from Shanghai University Medical College. Today, we will continue discussion on respiratory physiology. Last time, we have talked about the mechanism of normal breathing. Do you still remember the boy with asthma? It could be fatal. But how do we evaluate the function of a respiratory system in asthmatic patients? Let's discuss the evaluation of pulmonary function. Here are the learning objectives for this session. You should be able to first define and specify the named volumes and capacity. Then describe the dead space and how it affects alveolar ventilation. Finally, explain how FVC and FEV are measured and how they change in lung diseases. Pulmonary function is related to the gas flowing in and out of your lungs, recorded by this equipment and represented by this curve. You are doing normal, quiet breathing right now. So about 0.5 liters air flow into and out of your lungs each breath. This lung volume is called tidal volume, TV. Now, try your best to breathe in and out harder. The equipment will record a curve like this, called inspiratory reserve volume and expiratory reserve volume, IRV and ERV. Beyond TV, IRV can supply about 3.1 liters fresh air to your lungs, and ERV can get rid of another 1.2 liters air. These are important factors in conditions where more oxygen is needed, such as exercise. But even during ERV, the alveoli are still expanded like a balloon, since about 1.2 liters air remains in the lungs to prevent alveolar collapse. This is called residual volume, RV. So 4 respiratory volume can be recorded, and their specific combination make up our ventilator capacity. The inspiratory capacity, IC, is the total amount of air you can breathe in, and is equal to the sum of TV and IRV. Because you usually breathe quietly, ERV is not involved in normal breathing. So the total amount of air remaining in your lungs during quiet breathing is called functional residual capacity, FRC. It's equal to the sum of RV and ERV. The air involved in forced breathing can supply more oxygen for your body, called vital capacity, VC, which is equal to the sum of IRV, TV, and ERV. For a healthy young male, VC is around 4.8 liters. Final one is the total air in your lungs, equal to the sum of all volumes, called total lung capacity, TLC. However, not all the air in the lungs participates in gas exchange. Some just travels in and out due to the presence of a dead space, made up by conducting airways. At the end of inspiration, about 150 milliliter fresh air fills and stays in the dead space. When we breathe out, this air plus 350 milliliter from the alveoli will be exhaled. And at the end of this expiration, about 150 milliliter stay air from the alveoli fills the dead space. For the next inhalation, this stay air will move to the alveoli first. So the air in the dead space does not participate in gas exchange. That is why it is called dead space. Based on the definition of lung volumes and capacities, several indicators can be used to evaluate pulmonary function. The respiratory minute volume, refers to the total amount of gas in and out of your lungs per minute. So it is equal to the TV multiplied by the frequency of respiration. Normally, it is about 6 to 8 liters per minute. However, because of the presence of dead space, only a proportion of the TV air participates in the process of gas exchange. This is the important factor when assessing the concentration of O2 and CO2 in the alveoli. So the rate of the alveolar ventilation is proposed to evaluate the total amount of air in the alveola involved in gas exchange per minute. Normally, it is equal to 4.2 liters per minute. Besides quiet breathing, forced breathing is useful to evaluate the potential pulmonary function. The flow rate also provides important information. If you take deep breaths and then breathe out as quickly and as much as you can, the amount of air expelled is called forced vital capacity, FVC. During this process, the amount of air expelled in the first second, namely FEV1, accounts for about 80% of FVC, as shown in this figure. If this decreases to less than 50%, then we will have obstructive pulmonary disease. However, although FVC is also decreased in patients with restrictive pulmonary disease, like pulmonary fibrosis, the ratio of FEV1 over FVC can be equal to even more than 80%. Another parameter is maximal voluntary ventilation, MVV, which indicates the largest amount of air into and out of your lungs per minute. This measurement predicts how much exercise one can perform. Let's go back to the case of asthma. The allergens cause strong contraction of the bronchial smooth muscles, giving rise to obstructive pulmonary disease. It is difficult for the air to go in, and more importantly, for it to get out of the lungs. Forced vital capacity, FVC, is decreased, and FEV1 is dramatically reduced. The ratio of FEV1 over FVC is decreased accordingly. The net result is that more air is trapped in the lungs. By contrast, in restrictive lung disease, FVC is decreased dramatically in fibrotic tissues. Although FEV1 is also reduced, the ratio of FEV1 over FVC is normal, even higher than 80%. In summary, the evaluation of breathing is related to the air getting into and out of your lungs, including the lung volumes and capacities. This helps to distinguish obstructive pulmonary disease with increased airway resistance and restrictive disease with reduced total lung capacity. Here are the references. That's all for today. Thank you and see you next time.